And the last speaker will be Professor Caroline Griffin. She is the professor and deputy head of the Clinic of Nuclear Medicine at the University Hospital Leuven in Belgium, and she is also the chair of the Oncology and Theranostics Committee of the European Association of Nuclear Medicine.
Thank you. Good morning to you all. I also want to thank the organizers of this meeting to invite me to talk to you this morning about radiopharmaceuticals and how we can use them in modern cancer therapy. So I'm a nuclear medicine physician in contrast to my colleagues who are radiation oncologists. And for those of you who are not aware of nuclear medicine, this is a branch of medicine that uses radioactive drugs or radiopharmaceuticals either for diagnostic use or for therapeutic use. And our discipline, or the foundation of our discipline, was invented or discovered 125 years ago, more or less, with the discovery of radioactivity by Henri Becquerel, and then a couple of years later by the discovery of polonium by Marie Curie. And both of their names are still used in our clinical practice, as the SI unit for radioactivity is the Becquerel, and we will talk about gigabecquerel of activity. We also can use the Curie, so we have a millicurie or a microcurie that we can also use in our clinic. Then the development of radiopharmaceuticals was also not something that's new. This has been developed for the first time more than 75 years ago. And also radionuclide therapy, where patients are being treated with radioactive substances, is not new. The first patient with Graves' disease was treated already more than 80 years ago, and a couple of years later, the first treatment for patients with thyroid cancer was also delivered by Dr. Hertz. So how do we use these radiopharmaceuticals for, on the one hand, imaging, and on the other hand, therapy? What you see here on the slide is the basic structure that we have in our radiopharmaceuticals. So on the one hand, on the right, you can see the vector molecule. This is the part of the radiopharmaceutical that is responsible for the interaction with a target on the cancer cells. This is typically a receptor or an enzyme, a protein that is present on the cell membrane of the tumor cells. And the vector molecule is then linked to a radionuclide, and depending on the type of radionuclide that we use, we can have a radiopharmaceutical that we can use for imaging or for therapy. In this case, this is a radiopharmaceutical for imaging, so the radionuclide will emit radiation upon its decay, and this radiation, being a gamma ray, can then be detected by the PET camera. This is positron emission tomography, or a gamma camera. And you can see two examples of routinely used radiopharmaceuticals for molecular imaging on the left and the right. On the left, you see FDG. This is fluorodeoxyglucose. This is the radiopharmaceutical that we use most often in oncological patients. This is a glucose analog. On the right side, you see one of the more recent radiopharmaceuticals. This is PSMA, one of the PSMA radiopharmaceuticals that we use for prostate, as it targets the prostate-specific membrane antigen. And with these imaging tools, we can look at different functions of tumor cells. On the left, you can see the metabolic activity of tumor cells that we can measure with FDG, in this case, in a patient with lymphoma. In the middle, you see the PSMA compound that we use in patients with prostate cancer, where in this case, the lesions that you see are lesions that have PSMA expression on the cell surface. And on the right, you see an example of a neuroendocrine tumor, where the lesions that you see are lesions expressing the somatostatin receptor that we can target with tracers such as gallium dotatate. So, of course, these molecular imaging techniques with PET are also really at the forefront of staging, restaging, response assessment of all kinds of treatment that we are applying to our oncological patients in daily routine. By changing the radionuclide that we link to the vector molecule, we can also have radiopharmaceuticals that we can use for radionuclide therapy. In this case, the radionuclide will emit a particle upon decay, and this particle will interact with the tissue and will cause destruction of the target cells, in this case, destruction of the tumor cells, and have a positive effect for the patient. On the right, you can see an example again of PSMA. So the target will be the PSMA a protein on the cell surface, and in this case it is linked with lutetium, which is a beta emitter. We have several radionuclides available that we can use in radionuclide therapy, and here you see an overview of the different radionuclides that we can use, and they are grouped in 3 groups dependent on the particle that is being released upon radioactive decay. So we have either radionuclides that will emit electrons. These are beta-minus particles, and these are the ones that we most often use in clinical routine at the moment. And the 3 radionuclides that you see on top, so yttrium, iodine-131, and lutetium, these are the ones that we use most often in clinical routine. The electrons will interact with the matter or the tissue of the patient, and they will reach a couple of millimeters from the location where they are released. Then we have Auger particle emitters. These are not routinely used in clinic at the moment. And then we have the alpha particle emitters, where actinium and also radium are 2 of the radionuclides that have raised great interest over the last months. Alpha particles, as we already heard this from the first talk, also in the boron capture therapy, there are alpha particles that are being released. So these alpha particles are very active particles. They have a very high linear energy transfer, and they will cause a lot of damage to the tumor cells over a very short range, 10 to 100 micrometers from the location where they originate. So we can bring with our radiopharmaceuticals, we can bring the radiation really to the tumor cells and have an effect very locally. So although radionuclide therapy seems to be a hot topic, it is actually not so new at all. We've been doing iodine treatments, which is a form of metabolic radionuclide therapy for decades, treating patients with iodine-131 thyroid cancer patients. But also targeted radionuclide therapy is not very new. It has been around for more than 30 years, but we've seen a massive increase in the availability, the clinical use over the last decade. And therefore, in 2024, we have several EMA and FDA-approved radiopharmaceuticals that we can use for radionuclide therapy in specific indications in different tumor types. And later in the talk, I will focus just on 2 of them. I cannot focus on all of them, but I will focus on the 2 most recent ones, and that also really have boosted the use of radionuclide therapy in clinical practice. These are lutetium dotatate and lutetium PSMA treatments. So what can we gain by applying radionuclide therapy to patients? Radionuclide therapy is a systemic treatment that we will provide to patients with metastatic disease. So at this moment, there are no radionuclide treatments that we can really use to cure a patient, because most of the techniques are really used when patients are in a very advanced stage of their disease. But what we can use is very beneficial to patients. On the one hand, radionuclide therapy can have a strong effect on progression-free survival, and therefore we can control the growth of the disease. In this case, this is an example for neuroendocrine tumors. We can also have overall survival benefit and make patients live longer, but what is very important is that our radionuclide therapies also come with a beneficial adverse event profile, and therefore the time that patients gain is also qualitative time. So we can have a positive effect on quality of life measures. We can have a positive effect on pain, on symptoms. So we can also make patients live better in the time that they have left. In contrast to some of the previous speakers who have been talking about the lack of interest from industry and trials, we see the completely different story for radionuclide therapy, where at the moment we are seeing a huge interest from industry. And here on the left of the slide, you can see all different trials that are industry. And you see that there's many different industry partners who are all getting into the field of radionuclide therapy with different radiopharmaceuticals in different clinical indications. So there is huge interest, not only from industry, but you can also see that the investments, this is on the right, the investments that are coming into the field of radionuclide therapy are really becoming huge. The number of publications that we see in this field are also increasing very rapidly. So at the moment we have quite a number of nice clinical indications already, but I'm sure that over the next 10 years again, this field will really boom and we will see many more of these indications coming to clinic. So how do we use radionuclide therapy? When we use radionuclide therapy, we use a combination of diagnostics and therapy, which we call theranostics. And this is the principle of see it, treat it. When we apply when we deliver radionuclide therapy to patients, we will always start with imaging-based patient selection. And this is because we need to show that in the lesions of the patients, the target that we want to use is expressed in a high level. On the right, you can see two examples of two patients. One patient clearly has very high uptake in the lesions of the diagnostic radiopharmaceutical that we use in this case. This patient is a good candidate for radionuclide therapy and can proceed. On the left, you see a patient that has very few or no uptake of the diagnostic radiopharmaceutical in the tumoral lesions and is therefore not a good candidate for radionuclide therapy. The reason why we want to have high uptake in tumoral lesions and low or lower uptake in normal tissue and also long residence times of our radiopharmaceutical in tumoral lesions and more rapid washout in normal tissues is that we want to reach high doses of radiation to the tumoral lesions with lower doses to normal effects and therefore have an effective treatment with low adverse event rates. The way that we administer radionuclide therapy is mostly through an intravenous injection, and for the typical lutetium PSMA or lutetium dotatate radionuclide therapy schemes, we will do this in several cycles. This is 4 to 6 cycles typically with an interval of 6 to 8 weeks. And you can see the typical workup of a patient that would undergo PRT, which is the type of radionuclide therapy for neuroendocrine tumors on the right, with first an imaging workup. We also look at lab parameters, clinical parameters, and so on. And then the patient will undergo several cycles of the treatment. We will do interim follow-up with imaging, and then at the end of the treatment again follow up with the same diagnostic imaging that we used to select patients for the treatment. At the moment, most of the radionuclide therapy that is being delivered is still delivered in a fixed activity per cycle, regardless of patient-specific characteristics. But also there, we expect that in the coming years, we will see more individualized activity calculation. So the dose and also the activity that is being delivered to the patient will be more specified. So let me go into 2 examples. The first one is PSMA-based radionuclide therapy in prostate cancer. And in prostate cancer, the target that we want to use is the prostate-specific membrane antigen, and the theranostic duo that we use is a duo of a diagnostic radiopharmaceutical. This is gallium or F-18 labeled PSMA, which we use for the patient selection and response assessment, and then the therapeutic radiopharmaceutical, this is lutetium labeled PSMA, that we use for the treatment. The working mechanism is again depicted here in this figure. So the lutetium PSMA will bind to the PSMA target that is present on the cell membrane of the prostate cancer cells. This structure will then be internalized, and within the tumor cell, the radiation, in this case the electrons, will be emitted. They will cause DNA damage, and therefore they will cause the death of the tumor cell. We actually have very nice data on this treatment coming from a large randomized controlled trial. This is the VISION trial. This is a large phase 3 international trial that included about 1,000 patients with end-stage prostate cancer. So patients with metastatic castration-resistant prostate cancer who had received at least 1 prior novel anti-androgen drug and also 1 prior taxane. These are the standard treatments in patients with this state of prostate cancer. And patients were randomized in a 2-to-1 fashion between either receiving best standard of care alone or best standard of care in combination with the lutetium PSMA treatment. The trial had 2 primary endpoints, overall survival on the one hand and radiographic progression-free survival on the other hand. And what is very important, that in all the trials that you will see on radionuclide therapy, we will always have the proof of the presence of the target included in the inclusion criteria of the trials, and this is also what we do in clinical practice. So also in the VISION trial, patients were required to have at least 1 PSMA-positive metastatic lesion, and they were not allowed to have PSMA-negative lesions to be eligible in the trial. And you see that about 1/10 of patients was excluded because of these imaging-based inclusion criteria. The VISION trial was a very important trial for the nuclear medicine field, as it was positive for both primary endpoints. So the trial showed overall survival benefit for patients receiving lutetium PSMA treatment in comparison to standard of care, with a overall survival benefit, median overall survival benefit of 4 months and a 38% reduced risk of death. Also, the second primary endpoint was positive. Here you see the curves for the imaging-based progression-free survival, where you can see a large difference. Remember, these are very end-stage prostate cancer patients who have received many previous lines of treatment. So we have a median progression-free survival benefit of more than 5 months and a 60% reduced risk of progression. Apart from these primary endpoints, there are also many secondary endpoints that have been evaluated in the trial and that are important for patients' well-being. This is one of them. This is the time to the first symptomatic skeletal event. And again, you can see that patients that receive the radionuclide therapy have a longer time to first symptomatic skeletal event. And this first symptomatic skeletal event really causes a lot of morbidity to patients with this end-stage prostate cancer. What comes on the other side of the coin when we look at adverse events that patients will report when they receive this kind of treatment? We see that the adverse event profile is quite beneficial. So there are more adverse events when patients are receiving this very active treatment, but the adverse event profile is very well tolerated by patients. What we can see is some hematologic toxicity that is very well manageable in clinical daily routine. Some patients will require transfusion, but remember again, these are patients with advanced prostate cancer, sometimes with very extensive disease, who have already some hematologic toxicity at the start of the treatment. And then patients can also have some non-hematologic toxicity, where the major adverse event is increased fatigue. This is mainly in the first week after patients have received a cycle of radionuclide therapy. They can also have some nausea. This is in the first hours after we deliver the radiopharmaceutical and can be very well countered with preventive anti-emetic drugs. And then we have a very specific side effect that is related to the uptake mechanism of the radiopharmaceutical, and this is dry mouth, and this is related to the physiologic expression of PSMA, not only in the prostate, but also in the salivary glands. And when we administer these compounds in a systematic way, also the salivary glands will take up some of the radiopharmaceutical and will be irradiated in a low amount, causing a temporary effect of dry mouth. This is very specific for PSMA-based therapy. This is not present in the other types of radionuclide therapy. If we compare the lutetium PSMA to a very active compound that we have available in the same space of mCRPC, being cabazitaxel, second-line chemotherapy, this was tested in a phase 2 trial. Again, mCRPC patients, heavily pretreated, randomized in a 1-to-1 fashion between either lutetium PSMA or cabazitaxel. The trial was not powered to get overall survival benefit, but the primary endpoint was PSA decline over 50%. And again, there was a very strong inclusion criteria based on the PSMA PET scan, where patients were required to have positive lesions. And you see here the criteria that were used were even more stringent, as in the VISION trial, as almost 1/3 of patients were excluded based on these imaging-based criteria. If you look at the comparison of the two and you look at the PSA reduction that patients can have when they receive lutetium PSMA compared to cabazitaxel, you can see that about 2/3 of patients that receive lutetium PSMA have a 50% decline of PSA, while this is only present in about 1/3 of patients receiving cabazitaxel. Also, the progression-free survival curves were in favor of the PSMA treatment. And then in follow-up studies, we also saw the overall survival data. Remember, the trial was not powered for this, but you see that the overall survival is similar between the two compounds. And again, we see that that there was a lower adverse event rate when patients received the lutetium PSMA treatment in comparison to the cabazitaxel. Based on these data, this treatment has been approved by FDA and by EMA and is available in the US, in Europe, and is also already reimbursed in some countries, as in Belgium we were the first country to have Pluvicto, which is the commercial name of this Novartis compound, to have this fully reimbursed in clinical care. A second example that I briefly want to touch upon is a peptide receptor radionuclide therapy, or PRRT, which we administer in patients with neuroendocrine tumors. And the way that we administer this treatment is very similar as we do with the lutetium PSMA. So the workup is the same. We also use a theranostic duo for imaging and for therapy. In this case, the target that we use is a somatostatin receptor, where we, as you can see, also have several diagnostic radiopharmaceuticals available that we can use for patient selection. And this is similar to what I've already shown you. So a good candidate will have high uptake of the diagnostic radiopharmaceutical in the lesions. On the right, a patient with no uptake, therefore not a candidate for receiving PRRT. We also here have several therapeutic radiopharmaceuticals available. These are all beta-minus emitters. This is what we use in clinical routine, what we also have reimbursed, again, based on a randomized controlled trial. This is the NETTER-1 trial. This was a trial that included patients with mid-gut neuroendocrine tumors, and they were randomized in a 1-to-1 fashion between receiving the radionuclide therapy or standard treatment. Trial had one primary endpoint, progression-free survival, and as you can see, again, the positive proof of the target expression is included in the inclusion criteria. And here the trial was positive again for its primary endpoint, so there was a very strong progression-free survival benefit for patients receiving the radionuclide therapy. This trial was not able to show a significant overall survival benefit, although there was a clear difference in the overall survival, with 36 months in the control arm and 48 months in the radionuclide therapy arm. And also here, there are many patients that were in the control arm that crossed over to the active arm and that received lutetium dotatate treatment after the trial was finished. And the authors of the NETTER-1 trial also did a crossover corrected overall survival curve. There was in total 36% of patients that crossed over during the follow-up period, showing again a stronger overall survival benefit, not statistically significant, but clearly there. Apart from these very nice outcome measures, again, important for patients is that we also have a higher objective response rate, improved quality of life, and improved symptom control when patients are receiving radionuclide therapy in this setting. Again, very similar, when you look at toxicity, there is some acute toxicity. This is mainly some nausea, but it's not caused by the radionuclide therapy itself, but is caused by the nephroprotective amino acids that will be administered together with the radionuclide therapy. In the subacute period, days to weeks after the administration, it is again mainly some increased fatigue and hematotoxicity that can occur. And with long-term follow-up, which we have in neuroendocrine tumors, as these patients have a long overall survival, we can see low rates of kidney toxicity and also very low rate of persistent hematological dysfunction. This is what we currently have in clinical routine, but there are many ways how we can still improve the outcomes of radionuclide therapy. And here, this is an here you see some examples for prostate cancer, but you can make an exact same figure for radionuclide therapy and other types of tumors. So on the one hand, we can work on the radionuclide. We can link a different radionuclide to the vector molecule and have a more effective treatment. We can also work on the vector molecule, change the biodistribution so we have higher uptake in tumoral lesions and lower uptake in some normal tissues. We can also look at combination treatments, which is already being done in several trials. We can look at combination with chemotherapy. We can look at combination with other types of therapy. And then we can also improve the way that we use the imaging that we have available in these patients to tailor treatment. We can calculate dosimetry, we can do more patient individualized dose assessment, activity assessment. We can look at radiomics, AI, to further improve the value that we can have with radionuclide therapy. And just to show you one example, is one of the fast evolutions that we see is the move from beta particles to alpha particles. We see this in prostate cancer, we see this in neuroendocrine tumors, also in other tumor indications where trials are ongoing. And this is just one example, spectacular example of the power that we can have with alpha therapy. So this is a patient with very end-stage prostate cancer, high PSA value, as you can see, very extensive disease. The patient first underwent lutetium PSMA treatment, which, as you can see, was not effective in this patient. So the PSA went up and also the extent of disease increased further. Then the patient was switched to actinium PSMA treatment. Actinium is one of these alpha particles that we can easily link to the PSMA vector molecule. And when you provide this treatment to patients, in this case, patient only received 2 cycles, so 2 cycles with 6 weeks in between. You can see a very drastic reduction of the tumor load on the PET scan, also of the PSA value. And then patient received 1/3 cycle of the actinium PSMA treatment and actually was able to reach complete response on the imaging and also if you use the biochemical measure. What is interesting is that we can reach this super active treatment with only a tiny amount of actinium. If you calculate this treatment is being given with only 9 nanogram of actinium. So it's a tiny amount of radionuclide that we need or that we use to have a very drastic effect on patients, on the tumor load in patients. This is, of course, one of the spectacular examples. We're also starting to see some larger series. This is just one of these series coming from Mike Sateke in South Africa, with more than 70 patients being treated with actinium PSMA, all very end-stage prostate cancer patients, where you can see that this treatment is effective and gives a PSA reduction in 80% and even can give you a more than 50% PSA reduction, which is considered a clinically relevant response in 70% of the patients. So we're really looking forward to larger trials. There will be large phase 2 and even phase 3 trials going on with this compound in the next year, 2 years. So we will hopefully see the result in 5 years from now. Not only in prostate cancer, there is the move from beta to alpha therapy. This is also in other tumor types. This is just one example in neuroendocrine tumors, in this case with lead-212, also very interesting radionuclide for alpha treatment, where here in this case a small group of patients with metastasized neuroendocrine tumors was treated, where you again see a very good response rate, 80% response rate with this treatment. So to conclude, radionuclide therapy has been applied by nuclear medicine for decades. Modern theranostics allow diagnostic imaging of relevant molecular targets to make decisions on target-directed treatments. Radionuclide theranostic duos are currently being used in clinical routine practice. They are FDA and EMA approved and are reimbursed. Trials such as the VISION and the NETTER-1 trial have validated theranostic targeting of radionuclides to metastatic sites with a drastic effect on PFS and OS while preserving or even improving quality of life of the patients. And new theranostic combinations for novel targets in novel tumor types and radionuclides are eagerly being developed. We see a huge unlocked potential, not only us as a nuclear medicine field, but also industry, academic sites see this huge unlocked potential, and therefore I'm a very much strong believer in a bright future for radionuclide therapy in oncology. Thank you for your attention.
Thank you, Caroline, for excellent presentation. Any questions from the audience? You showed the kind of pipeline of the molecules that are awaited, and some of them are in clinical use. I see there a certain disagreement comparing to what is the future production capacity of radionuclides. Mm-hmm. During recent years, we have seen some shortage of several radionuclides because of service of old nuclear reactors and so on. Can you comment on this?
Yeah, that's indeed one of the big hurdles that we're facing at the moment. For lutetium, there was definitely a problem last year where we had shortages of the radionuclide for clinical use. I think at the moment, especially Novartis, who is who provides the Pluvicto, so the lutetium PSMA and also the lutetium dotatate to clinics, they have really invested in new facilities, not only to produce but mainly to purify and to label the radiopharmaceuticals. So at the moment for lutetium, the market is well covered. If we move to actinium, there the problem is much bigger. There's not a huge amount of actinium available at the moment, but also there are some initiatives of different routes of producing actinium that are being developed. For example, in Belgium, we have the SCK in Mol, who is involved in the Pantera project. This is a project that's really dedicated to producing large quantities of actinium for clinical use. So although this is still a problem now, I think there are several players, really big players, working on this. So I'm quite convinced that if these in 5 years or even a little bit longer, when these new therapies come to clinical use, we will also have the supply that we need.
In the 90s and early 2000s, there were several attempts in using antibodies in targeted radionuclide therapy without real success, I might say. It looks like the smaller molecules won the antibodies. Can we now forget antibodies and just look at smaller molecules in these applications?
I think when you look at the full-size antibody, probably the answer is yes. The circulating time is too long. We have too many side effects. There were, again, some recent publications that provided quite some adverse events that we don't see with the small molecules. So it's all about biodistribution. We want to have the radionuclides in the target cell fast, and we want to have it outside of the normal tissue also fast. So we want to have it accumulating in the tumor lesions and not in normal organs. And with the full-size antibodies, this is a problem. We also need long-living isotopes because it takes so long time before the antibodies actually accumulate in the body. And this, of course, also irradiates the normal tissue in a much larger extent. So personally, I'm really much a believer in the small molecules, but also the smaller antibody fragments. There are some great developments also in that field. So I would not discard antibodies as a total group, but really look at the smaller antibody fragments, and there are some great developments as well.
So today we heard 4 very interesting presentations on the modern techniques to target the tumors more precisely, and I think we can thank all the speakers once more.